Unfortunately, Dr. Wilson, who was supposed to have the next lecture, is not online yet, but we will continue now with the number 3. And the lecture number 3 is given by Dr. Giovanni Maconi from Milan, Italy. He is associate professor at University of Milan, and he is also the chief of the GI ultrasound department at Luigi Sacco University Hospital in Milan. He has also been a key person in the task force group of gastrointestinal ultrasound that has provided the 2 first guidelines that is now published, and he's also working hard with the next guidelines coming up. We have 2 more guidelines now submitted and 3 more in the pipeline. Altogether 7 guidelines in GI ultrasound, and Dr. Maconi is really a key figure in providing all these to you. So we are very happy that you could join us today, Giovanni, and please talk about the evaluation of deep remission in IBD using ultrasound. Please, Giovanni.
Thank you very much, Helge, for your very kind presentation. And also, good afternoon, everybody. Good morning for people like Stephanie, who is in Canada. So my presentation will be on intestinal ultrasound and the role of intestinal ultrasound in deep remission in IBD. Here are my disclosures, okay? And my talk will be presented on the treat-to-target evolution in IBD, what is changing in the last years, what is mucosal healing or transmural healing, and what is the best target now in IBD, and the deep remission, and in particular transmural healing in IBD detected by intestinal ultrasound. I will show you the data, the few data of the literature on this specific topic. So the first point is the treat-to-target evolution in IBD. What are IBD? IBD is a disease that usually involved young people, in particular in Crohn's disease, but then it persists all over the life. And nevertheless, the normal life expectancy in this patient is similar that we have with the other population, with the remaining population. However, this patient has a significant morbidity because of their symptoms that impair the quality of life. Most of these patients, in particular Crohn's disease patient, had surgery because the disease is characterized by bowel damage, in particular the development of strictures, and then fistulas, abscesses, and so on. So there is not only symptoms in these diseases, but also a bowel damage. That is what we can assess using endoscopy and imaging tools. And in these years, in the last decades, something has changed. Years ago, 30, 40 years ago, the main topic of our treatment was to save life and cure the symptoms of these patients. We have to cure only the symptoms. Then we realized that we have to maintain the symptoms, preserve the bowel, and also guarantee to our patient a better quality of life, possibly reducing the steroid use. More recently, we understand that mucosal healing can modify the disease of these patients, in particular avoiding surgery, disability, hospitalization, and also avoid several cycles of steroids, courses of therapies. And now something is changing also regarding the clinical assessment of these patients. Traditional assessment include assessment of a Crohn's disease activity index or a Harvard ratio index in Crohn's disease and Mayo score in ulcerative colitis. But more recently, also the patient's reported outcome has come to our attention. In fact, FDA is moving away from Crohn's disease activity index as a co-primary endpoint in clinical trials. And now we have a better attention, in particular in the reports of the patient about their symptoms, without interpretation of healthcare professionals. And these symptoms are usually stool frequency and rectal bleeding in ulcerative colitis, and stool frequency and abdominal pain in Crohn's disease. But we are gastroenterologists, I am a gastroenterologist, and we have a particular attention regarding the mucosal aspect, endoscopic aspect of the colon and the ileum of our patients. and this may impact on the prognosis of this patient. You can see here the colon with a deep ulceration, longitudinal ulceration in the colon in Crohn's disease. And after the new treatment, in particular the advent of the new use of biologic agents, in particular infliximab, adalimumab, and new target therapies for the bowel inflammation, we can have in the time an improvement of this situation with a healing of the mucosa, as you can see here after 1 or 2 years of treatment. And in fact, the healing of the mucosa, as you can see here, may probably improve the duration of the remission, the onset of complication and hospitalization, may reduce surgery, and so on. And up to date, the data of the literature seems just to show that the patient that have endoscopic remission after 2 years, during a follow-up of 3 and 4 years, have a high percentage of remission of corticosteroids, as you can see here in this trial. And also you can see that both in ulcerative colitis and in Crohn's disease, endoscopic mucosal healing have a better outcome considering the colectomy in ulcerative colitis and also the resected bowel segments in Crohn's disease. And you can see here that in the study that patients without mucosal healing have a higher rate of hospital admission and surgeries compared to patients with endoscopic mucosal remission. And also this mucosal healing has a great impact on hospitalization cost in every sense and also in the quality of life. So we have a lot of studies showing that we have to gain in our patients the mucosal healing instead of symptomatic remission in our patients. So the new target is changing last years. We tend not to have only symptomatic remission, but also the improvement and the remission and healing of the mucosa of our patients. Of course, we have 2 diseases, Crohn's disease and ulcerative colitis, but these are 2 very different diseases. Okay. In fact, we know that Crohn's disease is transmural inflammation and ulcerative colitis only a mucosal inflammation. So probably in ulcerative colitis, it is enough to use endoscopy. But to assess properly Crohn's disease, we probably have to use cross-sectional imaging like MRI and ultrasound, because in this case we can assess not only the internal layer of the bowel, mucosa, but also the entire thickening of the bowel wall, and so we have to improve the transmural inflammation of these patients. And so we waited for the next year a composite targets for our patient. We have to have both the clinical, of course, patient reported outcome remission, but we have also to have endoscopic and also imaging remission in our patients. And so what we have now in the literature supporting the role of transmural healing in these patients. So the first studies came from magnetic resonance, the so-called and very famous Maria score that combine the wall thickness, contrast enhancement, edema, and ulceration that has a very good correlation with endoscopic assessment of Crohn's disease. And also have a very clear cutoff to assess patients in endoscopic remission. That is the cutoff point below 7. After 7 points, we can have a moderate and a mild, moderate, and also severe impairment of the damage of these patients. In fact, in this study published by Samuel Fernandes from Portugal, where 214 patients have been enrolled, he observed that only a minority of our patients that are in disease with a disease in clinical remission have also a transmural healing. Only 16% of patients has a transmural healing, and a higher percentage also a mucosal healing. As you can see here, the patient that reached transmural healing here had less need of therapy escalation at 12 months, And as you can see here, the need of any outcome, of course, a worsened outcome like surgery, admission, and so on, was very, very less frequent in patients with transmural healing compared to that of patients with the mucosal healing and patients with the clinical remission without healing. But now what we have with ultrasound, the first study that has been published assessing the role of the meaning of transmural healing with bowel sonography is this study from the group of Naples from Italy. Fabiana Castiglioni showed that after a course of therapy with infliximab or azathioprine, after 2 years, the clinical remission has been reached by 60% of patients, but nearly half of these patients had a mucosal healing, and a minority, only a quarter of the whole population, has a transparietal healing. So transparietal healing was very difficult to obtain, with much more difficult to obtain than mucosal healing. In particular, when we use less powerful drug like azathioprine. In fact, it's higher using infliximab than azathioprine. Another paper is being published later. Other papers have been published later by other groups. But what do you mean with transmural healing? Transmural healing is a normalization of the thickening less than 3 millimeters with a normal stratified echo pattern with a very mild or absent vascularity, also assessed by Lindbergh score below 1, and a preserved elasticity that can be used also, assessed also with a strain elastography and with a strain ratio below 2. Regarding the other study that we have, this one is being published in a pediatric population by Fortunato Civitelli that showed that treating 32 children with infliximab or adalimumab and assessing of the outcome of the wall after between 9 and 12 months, she observed that the bowel wall thickening in patients with mucosal healing improved significantly, passing from 6 millimeters to 3.9 in these patients, while there was not a significant change in patients without mucosal healing. Also, the vascularity changed significantly, and the increased vascularity reduced in most of these patients. So the better outcome that we can have in assessing mucosal healing and transmural healing is the improvement of the thickness of the bowel wall, and in particular the vascularity that may be reduced and significantly reduced in patients who came into a deep remission. In fact, in this study, the group showed that despite of clinical remission, that is here, 56% of patients, a minority show mucosal healing, and only 14% of patients had a transmural healing. So mucosal healing, again, also assessed by ultrasound, not only by MRI, is a very strong marker of healing and improvement, the clinical improvement of these patients. And in this study, has been also observed that we can use both ultrasound or MRI with the same accuracy. In fact, in the study, the same group of Naples compared bowel sonography and MRI enterography in 80 patients with Crohn's disease who underwent 2 years of observation longitudinal study and who have observed after 2-year treatment with infliximab and adalimumab. This group assessed steroid-free clinical remission because of healing and of course also transmural healing. This is a clear example of transmural healing with here the picture and the sonographic picture before the treatment, okay, with a thickening of the bowel wall here, an increase of vascularization of the bowel wall of the color Doppler, and after 2 years here, you can see that there is a significant improvement of the thickness and not significant vascularization of the bowel wall. And also, of course, this can be also observed with the MRI here, in this case, you can see here a great improvement, and the other one, into one here, with enhancement, a significant improvement also by MRI. And this group showed that the results given by MRI and ultrasound are nearly the same. In fact, in these patients, we can see that only a quarter of patients assessed by ultrasound gain transmural healing, and was nearly the same obtained with the MRI. So we can use both these techniques, of course, with the advantage of ultrasound in terms of easy to use technique. It is less expensive, so it is better for this reason to follow up our patients. And the last study, one of the most recent study that we have in assessing mucosal healing is this Spanish study, where 51 patients have been treated with biologic therapy. And this study reports assessed bowel wall thickening, color Doppler, enhancement by contrast enhanced ultrasound, and assessment of other complications of Crohn's disease. And these patients have been assessed at 3 months and at 12 months. He observed that we can have a significant improvement of inflammatory subscores, in particular after 12 weeks, and more slowly at 1 year here. And this inflammatory subscore usually involves mural thickness, color Doppler, of course, and increase of mural enhancement at seals. As you can see here, there is a reduced thickening at 3 months, and the persistence of reduced thickening at 1 year, with no enhancement at power Doppler or seals. On contrary, we can have also patients with complication subscores that are patients with transmural complications like fistulas or stenosis that have a very scarce enhancement, very scarce improvement of the very slow improvement of the bowel wall thickening. And you can see here that the thickening is sometimes not so improved at 3 months and remain unchanged also at 1 year. So we have patients with a clear improvement of the thickening, and patients that have no improvement after 12 weeks and at 1 year after treatment with infliximab. This has a very clear impact on the outcome of these patients. In fact, the patient that had at 12 weeks, at 1 year, a transmural healing did not change the medication here and have a significant better outcome compared to patients with lack of changes of the mucosal, the transmural healing. In fact, these patients that did not change are an intensification or a change of therapy and sometimes also surgery. So it seems that to have a transmural healing at 1 year, assessed by ultrasound, assessing, of course, thickening and also vascularization of the bowel wall, has a significant impact on the outcome of this patient. And this means also that we can also stop the medical therapy and also change the therapy in a more economical and also less expensive therapy than infliximab and so on. The last study that I would like to show you is that this last study using elastography. It is a very preliminary study that is being carried out in 31 patients. Also, these patients treated with biological therapy that were followed at 3 months and at 1 year. The authors assessed the bowel wall thickening and also the strain ratio observed with strain elastography. And in these patients, the population patients, stenosis have been excluded. So they are patients that have probably an inflammatory disease. And this study observed that the patient with a thickness of the bowel wall, in this patient, the thickness was not correlated with the outcome, in particular, to be operated or not. On the contrary, the strain ratio, the elasticity at the baseline, not during the therapy, but at the baseline, as a very prognostic sign, may be a very interesting prognostic signs. In fact, the patient with an increased strain ratio has a higher percentage and a high probability to be operated compared to other patients. And in particular, you can see here in this curve that patient with a increased strain ratio has a very, very high probability to be operated in the follow-up of 14 months compared to patients with a very soft, not increased strain value at the baseline. And the final message of the study is that the strain ratio can be an important prognostic sign assessing, of course, transmural healing. In fact, here you can see that the patient that did not gain transmural healing has a very high strain ratio compared with the patient who gain transmural healing. So this is my last data showing that ultrasound may play an important role in the future to monitor our therapies in our IBD patients, in particular to assess the outcome of patients to decide if you have to increase the dose of our drugs or we can suspend the treatment in our patients. So the final message is that we have today not only endoscopy, clinical assessment, bioclinical and histological assessment, but more and more importantly, the use of ultrasound like other imaging to manage properly our patient and to guarantee to these patients a better quality of life in the future. Thank you for your attention.
Thank you very much, Dr. Maconi. That was a really excellent lecture, and we have opened for some questions. And the first one is from one of the attendants out there in the world. And as you are an expert also in surgical cases, Maconi, I think this is a good one for you. He asked, in case of surgically altered bowel anatomy, how do you trace the bowel? Do you have any tips there, Giovanni?
I don't understand exactly the question. The question is how ultrasound can influence the surgery or...
No, if you have patients who have undergone a lot of surgery,
yes,
the anatomy is changed. Do you have any practical tips how to trace them in those cases? For instance, neoterminal ileum, where do you look for that? This is
very important. When we assess patients with Crohn's disease who have been operated, we have to know the kind of surgery. We have to consider now that most of our patients has been treated with laparoscopic surgery. And more and more patients have been operated more than once. More than a quarter of patients has been operated 2 or 3 times during their life. And frequently, the second and third and fourth operation are conservative surgery. That is a quite different type of therapy. So we have to know exactly before starting with the ultrasound to know the kind of surgery in our patients. Just to assess clinically better, the site of recurrence.
That is so true. So we have another question. You showed us some data on elastography of the bowels, and we have one question. How about the shear wave elastography to assess elasticity in the GI tract? Is that something they can do?
Yeah, we have up to now 7 studies on the use of elastography in Crohn's disease. 4 studies using strain elastography and 3 shear wave elastography. The data of the literature did not show better results with one technique compared to another. They are quite similar in assessing the stiffness of the bowel wall. And in particular, we don't have so far comparative studies with the shear and shear wave elastography. Okay,
thank you. And finally, the last question. What about patients with normal wall thickness on ultrasound, but after lesions on ileocolonoscopy? Do they have the same prognosis as other patients with transmural healing?
The patient, if I correctly understand your question, the patients with the transmural healing seems to have up to now, according to the preliminary data, the best outcome that we can have. We have very, very few data, but if you would like to have the best outcome for your patient, it is better to gain transmural healing instead of mucosal healing. So because of healing, transmural healing means a more deep remission. And so we can assure a very longer period of remission compared to only mucosal healing.
Okay, I think we have to move on. Thank you very much, Dr. Maconi, for your excellent lecture.